checkup and community-based center, instead of being center-based, being community-based cardio rehab. We are looking into that. We're really looking to see whether our sister facilities like LA County UC or Harvard, they can have a champion there and then become the community-based type of leader. And so we'll avoid the patient traveling. Yes, and hopefully with that improves adherence, yes.
I was just going to make a comment to what Dr. said here. At Healthcare Partners in the California market, a few years ago, we did a study alongside RAND where we took a controlled group of patients with diabetes, and we incentivized them $40 for every 0.5% in their A1C decrease. And actually, we did see over that 2-year period a significant decrease in about 6 months, and then it plateaued, stopped coming, worsened in their A1C, and then we saw them come back to potentially just benefit from that financial incentive. So we saw it not with CHF, but we did see it with diabetes. But we saw that over that 2-year period, it was like 6 months where we saw the most drastic A1C difference and a very significant financial benefit for the patient. So.
Yes, and I'll share this. Many times we hear the patient, just stop by when DOTs are providing the education about nutritional and preparation of meals. And many of them said, you're asking me to use fresh vegetables and fresh fruit. I can afford only canned food. And if you could somehow maybe even say, instead of canned, we get you the fresh vegetables. So maybe, some kind of vouchers to say, for this healthy. And I see that how can it be, paired together, yes.
So, I agree with that. Majority of the times, we are, telling them what we know, what's in textbooks, but we're really not looking at what they can afford, what they can do, what their surrounding is. So I think as health educators, it's very important to know a little bit of who you're talking to. Because if you tell somebody, like the patient I told you, and give him some books, pages to read and do this and do that, he's gonna take all that, go home and be even more depressed. Yeah.
Yes.
Again, I have 2 questions.
Okay.
And the first question is for both of you. Excellent presentations. What about pre-event rehab? Someone is identified with all the risk factors, diabetes, hypertension, smoker. We know they're on a bad road. So let's get them into some type of intervention, rehab, before they have their acute coronary syndrome, before they have their MI, and not only to improve their overall health, but maybe get them stronger for the rehab they're going to need post-event. So
So pre-rehab or pre-MI?
Pre-event, so my
Pre-event,
pre-event.
right?
Yeah, pre-event.
Yeah, so
Yeah.
that is you, Dr. Emmons, you're thinking the right way.
Yeah.
But you know what they tell me? There's no medicine and there's no money in America for preventive care. There's money for sick care. So believe me, this is the fight I'm having with every healthcare system.
I have
And
a
they tell me,
solution.
okay, then tell me the solution. Let's lobby that. I think that's what's most important.
And Dr. Aranguri
Yes.
kind of mentioned this, is that when you go to your administrators, you have to show them the amount of money that they're losing, especially from Medicare, by not meeting certain criteria. And that money that they're losing, which they don't see, it's totally separate. It's a different silo than what they see that they're collecting from when they, and once they put those together, they can see, oh, wait a minute, when we put this pre-event patient in, not only are we going to cut down on our hospital rates, not only are we going to improve their blood pressure, diabetes, and other HEDIS scores, so that we don't get this negative dollar effect overall, because it's a negative dollar effect on their whole Medicare budget.
It is true,
Yeah,
and
not
that
only
is,
that, but you.
and that's what we're trying to show.
Yes.
And believe me, then they talk about, okay, HCC coding, they talk about so many things that after, so the whole, I feel the healthcare system, we're going there.
Yeah,
What you're
yeah,
saying
yeah,
is
yes.
where people like you and this RightCare initiative and all the thought leaders here are moving towards that.
Right.
But today, unfortunately, we're still stuck in that
I understand.
space
Yes.
of sick care.
I will add that today there's a very clear demarcation, primary prevention and secondary prevention. I think at this point, there is more support in secondary prevention than primary prevention. I agree, it should be primary prevention. Why wait until somebody needs a cabbage or a valve if we can prevent that?
Right.
Definitely, I mean, no question about it, but I think, still, we haven't reached that point, and we just remain between primary and secondary prevention.
The second question I had is, Doctor, you mentioned, and you probably did too, we lose these people to the follow-up. They don't complete the program, they don't start. And I remember a guy, because I go to rehab 3 times a week, and I will for the rest of my life, but I remember a guy who dropped out because, he dropped out of the Cesars program because, you know where Cesars is, and he lived down in, I think it was Long Beach or someplace. That's a
Gonna give
great
you
distance,
stress.
and you brought up.
Yeah.
So I thought, well, why don't we have a network of rehab
Mhm.
so that everyone in this network will come together, they'll have the exact same criteria, they'll be educated in the same way, they'll have the same goals and the same program, and then a patient can go to their local rehab and report back to the central location, so you don't lose that patient. Your numbers are increased, your overall improvement is increased. And I think if you approach some of the payers with reduce and do some shared savings through reduction, that would help pay for that program. So I don't know if there's a question there, but I throw that out as a possibility.
I think it's a great point, and that's what we're trying to do when we're in local
Yes.
sister facilities, identify them, go talk to them, send them invitations for them. In our experience, what it was worked the most is our coordinator reaching out the discharge planners. More even than actually at the level of chiefs and department heads. The discharge planners are very, very helpful on that. So, we have to keep that relationship and actually grow it in order to receive all the referrals. And now the second phase will be reaching out to them and say, you have to have a local champion. We are in the same system. We belong to the same network. Right. So we can help you to develop a remote and cardio rehab center.
Right.
Yes, that is the next step. It's a great point, yes.
Yeah, I have 2 questions, I have to keep up with the kids, but I have to. One is, I mean, ideally, the 36 visits and then long-term after that is important. Is there some evidence to show some linear benefit on outcomes, whether mortality or repeat admissions, if you do 12 versus 24 versus 30? I mean, you're still getting something by doing at least something.
Overall, even if you do a few sessions, you do better than the one who didn't do anything. But it seems that the plateau is around 25 sessions. That doesn't show any that it will be 25, 36. Maybe in the future it will be down to 20, 25. But the original study and that have been used as a references are 36 sessions.
And then, with respect to some of the issues we're talking about here, guidelines, societal guidelines, either from ACC or rehab, they're out there.
Yes.
Are you finding that the health plans that you deal with are pretty much following those as far as authorizing rehab, or is there variation across?
For our patients that have coverage, we don't have a major, and I can tell you also that our service of authorizations and our creators and the one originators are very good. They are right there. So, what we had to do is initially we had a meeting with the coders and show them the 7 indication with the right CPT codes, so they already know exactly what code to use and then the particular wording that needs to be utilized in order to get approval. And that was key. initially we had about 6 months trial, and it happened especially in the inpatient cardio rehab. And then we kind of share with them what were the main diagnoses. One classical example, let's say the patient comes with decompensated heart failure, and they're having a device. So the main discharge diagnosis is pulse defibrillator implant. That diagnosis won't support the cardio rehab. So cortisol, no, they had to go back and put this is a systolic heart failure that is compensated less than 12 months, and then it gets approved.
Thank you so
Oh,
much.
thank you.
And thank you to our three fantastic speakers. These sessions are always so good, and I think, Hattie, the work is to work out how we take all this knowledge and bring it together and get that community that they managed in San Diego to work in Los Angeles, which is, as we all know, for many reasons, much more challenging. But thank you again to three amazing speakers and to everybody. And I think, Hattie, there's a July break, is that right?
We're going to take a vacation in July and reconvene in August, so you do have the dates in your email. I'm sorry, I'm away from my notes and I don't have the dates with me. Megan, did you say this date? The date, I think it's Thursday, August 15th is from my memory. But we will be sending you something about that shortly. We are hoping to have USC's Right Meds Collaborative combined with the your very innovative occupational therapy program around blood pressure for August 15th. Alyssa Mayer is looking into that. And Carol, maybe you could say a few words about what that Life Redesign program is about.
Well, we had a discussion on Friday with the working group that we have a occupational therapy-led program at USC. We have the top occupational therapy school in the US, so it is very academic. They do a lifestyle redesign program. Lots of members of staff use it, but it's also used for patients, which is about setting goals, thinking differently about your life. And we're going to use, or we are using that now in a hypertension control program, which we're doing for initially just a pilot for 50 members of our USC population with high blood pressure and using pharmacy to do that. So it's it's fairly well proven that better control, quicker, easier, cheaper if you don't use cardiologists or doctors all the time. So we're using occupational therapists and pharmacists primarily. So we will have some data to share with you, but also a general discussion about, other ways to treat patients as well as just doctor's visits.
Wonderful, thank you.
But thank you everybody
Happy
for a
summer
wonderful meeting.
holiday, everyone.
Maybe 10 minutes.
Away.
I'm gonna go out there and try to.
Sometimes.
Sounds good.